A very warm welcome to this talk. Today I am talking about pediatric burns. I think a couple of days ago somebody asked me to make a lecture on pediatric burns. So I thought, okay, well, let's go with this thing. So we will start with the definition and then we would be talking about some of the statistics regarding pediatric burns. Then we'll move on to discuss the types of burns. Uh, we'll be talking about its management and we'll be also talking about its complication. So without further ado, let's dive in and get started. So the first thing is the definition. So the definition of burn is that it is defined as a skin and tissue damage caused by thermal application, which can be heat as well as cold, radiation, physical energy, and chemicals. So what does this mean? It means that burns is basically destruction of the skin along with associated tissues, and these tissues are lying beneath the skin, and this tissue damage can be caused by thermal application. So anything that is related to cold and heat. So on one extreme it can be an extremely hot object or source, any source that is liberating a lot of heat. On the other hand, it could be an object which is extremely cold. So on both extreme, extremely hot and extremely cold, these are the two different extremes of thermal energy that can destroy the skin and an associated tissue, resulting in burns. So one thing is that it can be caused by thermal application. It can be caused by radiation. So radiation means like ultraviolet radiation. It could include gamma radiation, uh, other types of radiation. It can also include physical energy, somebody falling off and having a friction against a pavement or a rough surface causing a friction burn. And it could be chemicals as well, which mean acids and alkalis. So it could be a wide variety of reasons. It could be thermal reasons, it could be radiation, it could be physical agents, and it could be chemicals. And these can result in damage to the skin and underlying tissues. So that is defined as a burn. Now, all over the world, and these are the World Health Organization statistics of the 2018, and they say over the year in 2018, 180,000 deaths occurred worldwide because of the complications associated with burns. As far as the local data is concerned, here in UK, around 250,000 people they suffer burns. So this is not the pediatric data. This is like the whole data. So it includes children as well as adults. So every year, 250,000 persons they suffer from different types of burns. Now, 10% of these 250,000 they require some form of hospitalizations or some form of inpatient care in the form of like dressing, or they might be needing some form of support like surgical debridement. They might be associated with some form of complications like superadded infection, so on and so forth. Only 1% of these 250,000 have got life-threatening injuries, which means that they have been burned to the extent where the burns they are actually threatening their life. And again, of these burns, majority of them they occur at home and majority are accidental. So again, most of them they just occur because of carelessness. And again, it's usually occurs, most of these injuries they happen at their own homes. Now, as far as the pediatric data is concerned, so let's talk about pediatric statistics. And again, I'm quoting most of the UK data. Every year, around 26,000 children under 5 years of age, they suffer from form of burns. And usually most of these burns are scaled, but anyhow. So every day, like every single day in UK, around 13 children, they are admitted to the hospital with burn or scald. So every day, 13 kids in the whole of UK, down from north down to the south, they are admitted because they have got some form of burn. And again, majority of these children, they get burns by scalds. Scalds means that it's basically very hot or liquid. So they can get scalds because accidentally a hot coffee or a hot tea or hot water gets spilt on them. Some of them they get injuries by contact. So a child getting in contact with a hot object, like putting their hands on a barbecue grill, or accidentally touching a hot oven hob, or like again accidentally touching something which is very, very hot, like hair straighteners. It could also be because of flame, like people who are doing barbecues and suddenly a flame burst or something can burn them. Similarly, electrical burns, usually in children, it happens if the children, they are biting onto the electrical cords, and they can get burns around the face or mouth. And last but not the least, friction burns, in which like kids who are playing around, like say most of them, they are on their cycles, and they accidentally get knocked off from their bicycles, land on the pavement or rough surfaces, getting like grazes around their elbows or knees, causing friction burns. So this is some of the key statistics surrounding pediatric burns. Now, as far as the types of burns are considered, we broadly classify them into superficial and deep burns. And how do we classify them? I mean, what's the basis of this classification? I have to give you a little bit of knowledge about the anatomy of the skin. So our skin consists of the top layer, which is known as the epidermal layer. And then we have got the dermis, underlying dermis. And beneath the dermis, then we have got the subcutaneous tissue, which mostly contains the subcutaneous fat, along with the blood vessels and other structures which are running around. That could be muscles, ligament, etc., etc. So the epidermal layer has got 5 layers. So there is a basal layer from where the cells, they multiply and then they go up. So the top surfaces of the skin, the epidermis, are actually dead skin cells. So if a burn is just confined to this layer, epidermal layer, so we call it a superficial burn. Or even if it is extending into the dermis, into the top layers of the dermis, not the deeper layer, then it is also classified as a superficial burn. So superficial burn can include just the epidermis or the superior or the top part of the epidermal layer, of the dermal layer. That would be classified as superficial. While the deep one burns are those burns which involve the lower half of the dermis layer, the lower half of the dermal layer, because the lower half of the dermal layer contains the nerve ending, it contains the blood vessels, and it can also include the subcutaneous fat and the blood vessels and the tendons and the muscles underlying tissues that are classified as deep burns. So again, as I told you, they can be further divided superficially into epidermal, where only the epidermal layers are involved, or they can be called as superficial partial thickness burn. Superficial partial thickness burns means that the burn is extending to the top layer of the dermis. Then the deep one is the deep partial thickness and the full thickness burn. So the deep partial thickness burn means that the burn is not only involving the epidermis and the upper part of the dermis, but it is extending down into the deeper part of the dermis, where most of the blood vessels, where most of the capillaries, where most of the nerve endings are there. Or it could go further down and then involve the subcutaneous fat, subcutaneous tissues, which could be muscles, ligaments, etc., etc., and then it becomes a full thickness burn. So what are the characteristics of these different types of burns? So if the burn is just like confined to the superficial epidermal layer, it's just like extending into the epidermis and it's not going down, then that burn is usually very red and dry. So normally we see it like in summer season, especially in the northern hemisphere here in UK, kids who are playing outside with their shirts off or not using sunscreens, they usually get like very red skin, which is usually painful as well. And that is what we call as epidermal burns, also known as sunburns. That is the one of the classical examples of epidermal burns. And remember that when we are doing the surface area estimation of the burns, erythematous area, or in other words, epidermal burns, are not included in the total body surface area when we are counting the percentage of the burns. Remember, this is the important thing. Only the superficial partial thickness, the deep partial thickness, or the full thickness are involved in when we are calculating the total area which is burnt by the burns. The epidermal burns are not included because it does not go down. It does not include blistering, and the skin is just red and dry. So it is erythematous skin. Then coming down to the superficial partial thickness burns, this is one of the most common burns that we see in our practice. Here, what happens because of scald or because of dry heat, like a flame or being contact with a hot object, the epidermal layer is burnt and the burn is actually extending into the superficial or the top part of the dermis. So what happens, because if again I draw this is the, let's say, the epidermis, and then this is the dermis. So in the lower part of the dermis layer, we have got the blood vessels. So if the, this is the epidermis and this is the top part of, so if the burn is extending to this area, what would happen is that the, because there is coagulative necrosis over here, the dead tissues and other things, and the inflamed cells surrounding this area, they would release cytokines. These cytokines would lead to increase in the vascular permeability of the cells. So what would happen? Fluid would leak from these blood vessels and go into this area. So what would happen? There would be vasodilatation of the blood vessels. The nerve endings would be stimulated, so they are very, very painful. So these burns are very painful. And what would happen because of this leakage of the fluid along with the dead skin, especially the weakened epidermal skin, that would lead to blistering. So you would see fluids filled bubbles, which are known as blisters. So the characteristic of the superficial partial thickness burns, which is one of the most common burns that we see in practice, that the skin is moist. The skin is quite moist and is weeping. So you can see the fluid coming out from the raw surface. Why? Because of the vasodilatation leading to fluid extravasation, and that fluid is being, you can see it on the skin surface. And I told you it can lead to blister formation as well. Why blister formation? Because there is fluid coming from the opened up capillaries, and this fluid is actually, if there is a dead skin on top of it, especially the epidermal layer, so it would balloon up and form a blister. And these are very, very painful because the underlying nerve endings, the nociceptive receptors, they are stimulated not only by the cytokines, but by the damaged tissue itself, and that leads to pain in this particular area. So these are very, very painful. These burns are very, very painful. Then coming down to the deep burns. So the first type is a deep partial thickness. So deep partial thickness, what happens is that, again, if I draw the skin, this is the epidermal, and then you've got the epidermal. So now the burn is not involving this area, but it is extending down to the deep layers of the dermis as well. So you've got the epidermis and you've got the dermis. Now the lower end of the dermis, if the burns extend to that, then you have got the blood vessels over here. The blood vessels would also be damaged. So when the blood vessel would be damaged, they would be coagulated. They would be coagulated. While the blood vessels in this area is coagulated, the surrounding blood vessels would become hyperemic because of the cytokines release. So you would be having vasodilatation and some edema in the surroundings. So you might get some blisters at the edge because of the extravasation of fluid. But the burn itself would be sort of a pale area. And this pale area is non-blanching. Remember that in superficial partial thickness burns, if you press on the burn area, it would blanch. Why it blanches? Because the capillaries are dilated, they are not destroyed. So you press them, it becomes pale. You release the pressure, it would again become pink. So they are always and always blinding. This is a very important clinical sign in differentiating superficial partial thickness from deep partial thickness. Remember, whenever there's a burnt area, and sometimes it is very difficult to decide if the burn is a superficial partial thickness or a deep partial thickness. So how do we know? Again, as I said, the skin would be blanching in case of a superficial partial thickness burn, and it would be non-blanching. Remember, it would be non-blanching in case of deep partial thickness. So the burnt skin is non-blanch. This is how you differentiate if you cannot determine just by looking at the burnt skin, because blisters can be a feature of both of deep superficial partial thickness and deep partial thickness burn as well. So remember, why it is non-blanching? Because the burn is extending down into the deep dermal layer, and the deep dermal layer contains what? It contains nerve endings, it contains blood vessels. So when the blood vessels would be destroyed, what would happen? It would lead to non-blanching area. When the nerve endings would be destroyed, it might be less painful or no pain at all. While the full thickness burns are rather easy because they are waxy white, they are not pink at all, they are waxy white, they are just leathery. They might be complete leathery white or they might be charred black. And skin is quite dry and inelastic. It's not weeping, it's very dry. So if you see a dry burn, like a crater full of black material or leathery, waxy material, that is a full thickness burn, which is also known as a 3rd degree, or some books even say 4th degree burns. And it is not painful. Why it is not painful? Because the burn has got down into the subcutaneous tissue, and obviously it has destroyed all the nerve endings. It has destroyed the blood vessels, so you don't see any blanching. You don't feel pain at all when somebody has got a deep, full thickness burn. So there are 4 types of burns. 2 are classified as part of superficial burns, 2 are classified as part of deep burn. So the superficial are just the epidermal burns, like sunburns are one of the common examples. Then we have got the superficial partial thickness burns, which are moist, they are painful, the skin blanches. These are the most common types of burn that we see in kids, usually caused by like spilt hot fluids, tea, milk, coffee, or being in contact with hot objects, like accidentally touching a hot oven hob or touching mom's hair straighteners, so on and so forth. Deep partial thickness burns can occur when the extent of injury is more as compared to one. So if there has been more contact, like the time of contact was more, then it can lead to deep partial thickness burn or full thickness burn. These are more common with electrical burns and so on and so forth. So this is how we can differentiate between these 4 types of burns. Moving on. Now, if somebody has got a burn, irrespective whether it's a 1st degree, 2nd degree, 3rd degree, what should be done? Remember, so we here in UK say that everybody should remember the 3 C's. So what are the 3 C's? Cooling the burn, calling for help, and then covering the burns. So remember, whenever you see a burn, whether you see it out of the hospital or whether you see it within the hospital, and if the burn has not been cooled by the parents or by the first aid providers, then it is very important that the burnt area should be run on with cold water for at least 20 minutes. 20 minutes is the recommended minimum time period for which the cold water means water which is around 15 degrees centigrade. It doesn't has to be ice cold. It means water around 15 degrees Celsius. So that has to be run on the burn for 20 minutes. Then call for help. Obviously, here in UK, 999 is the emergency number, or we have also got the NHS 111, or parents are advised to directly go to A&E. And at the same time, once the water has been run, it is important that the burn is covered. So usually cling film is a good thing to cover the burn, and then you go to the local hospital or an emergency department to get the burn assessed and treated. Now, at the same time, it's also very important that especially small burns, which are very painful. I told you the superficial burns are very painful. So that's why it's important that appropriate analgesia is given to the child. At the same time, even if you are in a hospital, if you are managing these small burns like the superficial burns, then before you go on debriding them and putting them in a dressing, it's important that you always start with giving them good analgesia. So it's important that you give them paracetamol, you give them ibuprofen, or if it is too much painful, then you can go for very strong painkillers as well. You can give them morphine. We use the oral form of morphine, which is known as Oromorph. Some centers even use the nasal morphine, which is known as the nasal diamorphine, intranasal diamorphine. So depending on your local policy or depending on whatever drugs you have got at hand, you can use that. So it's very important that you use appropriate analgesia before you start doing the debridement and you start doing the dressing. It's also very important that you take proper images. So whenever there is a burnt area, it's very important before you start something, you need to take the images, because that images can be used by the tertiary burn center to assess the burns and giving you appropriate expert advice. It might also be very important, especially in cases where there are like doubts around the cause of the burns, like non-accidental injuries. So in that case, these photos would go a long way in determining how this injury happened. So remember, you have to take images before the debridement and after the debridement, and depending on your hospital policy, you might have to share it with your area burns network and get an expert advice. Regardless of that, whether there is a sort of a mechanism to send images or not, usually the management of burn consists that you de-roof the blister. If there is any raw area, you properly clean it, you properly debride it, and then it is appropriately covered by dressings. And these dressings have to be changed every 48 hours. And usually for for these superficial burns, a week to 2 week times is enough for appropriate healing. So usually they are wrapped in sort of impregnated paraffin dressings. We call them Gel-O-Net dressings, and a few layers of Gel-O-Net dressings are applied on the burn area, and that is changed every 48 hours for 1 to 2 weeks till there is proper healing. At the same time, it is also very important these days we do not treat the burns with routine antibiotics. Please keep it in mind. Do not treat the uninfected burns with antibiotics. It will just lead to resistance. So we here in UK, we do not routinely use antibiotics unless and until there are proper signs and symptoms of infection. For simple burns, superficial burns, uh, just like paraffin dressing, non-adhesive dressings are more than enough. You would only prescribe antibiotics if there is a secondary infection. So at the same time, when we are addressing this, we tell the parents that they have to come back if there are any signs of infection. So it's very important to tell them that if the child develops fever, if he develops vomiting, rash, diarrhea, like signs and symptoms of toxic shock syndrome, which is caused by staphylococcal exotoxins, and that is usually a theoretical risk with any burn, then they have to come back immediately because that would require antibiotic treatment. So these advice has to be given. In most of the hospital, we have got like printed leaflets which mentions all these danger signs and what to look for and when to come back. If not, you have to give this advice verbally to the parent. So remember, first it's very important that is run cold water for 20 minutes, then call for help, go to the local emergency department, and meanwhile you can just cover the burn in a cling film. Now for major burns, obviously small burns doesn't require that you have to do your ABCDEs because the child is fine, otherwise he's just crying because of pain. So the important thing for minor burns or just for superficial burns is that you give them appropriate analgesia, you do the proper debridement. So if there is a blistering, it's important that you de-roof the blisters, because number one, it is important you need to assess the degree of the burn. So for that, you have to de-roof the blister because you don't know what is underlying. So you have to de-roof the blister. The other thing is you have to de-roof the blister because the underlying like fluid or gelatinous material and the dead skin, if you don't remove it, it would become a very good culture media for the bacteria. So it has to be de-roofed properly. Anyhow, if somebody comes with major burns, like that can happen in building fire, somebody getting trapped in a burning building, or industrial fire, things like that. Always remember your ABCDEs. So somebody comes with a major burn, airway takes priority, especially if they've got burns of the head and neck area. Remember, if somebody has got burn around the neck area, you always have to assess the airways. If somebody has got like soot around the nose, or if they have got synced nasal hair, or if they have got inhaled let's say hot gases, then it's important that you involve the anesthetist right from the very beginning, because it might take seconds to minutes for the airways just to swell up and would lead to airway compromise, which can immediately kill the child. So it's very important that these kids who have got like evidence of burns to the hair, to the facial area, to the neck area, or if there is like evidence of synced hair, then nasal hair, then you have to call the anesthetist and they have to be intubated. At the same time, you have to check for breathing as well. I mean, remember, so again, If they have been in the hot environment, again, they might have inhaled a lot of carbon monoxide. So remember, you have to attach them to the monitor, look at the saturation levels. It's also very important that if they have been involved in a major fire, then you check their carboxyhemoglobin levels, because it's very important. And remember, we have to take the corrected saturation levels. So the corrected saturation levels are your saturations at room air minus the carboxyhemoglobin levels. That would give you the correct saturated, because sometimes even in carbon monoxide poisoning, the saturations can be normal. So they can be quite deceiving. So it's important that you take the carboxyhemoglobin levels and you subtract it from the recorded saturations to give you the actual O2 saturations. So breathing, remember, for major breathing or major fires, or those who have been trapped in sort of a burning building or something, you always give them 100% oxygen. So 100% oxygen, you just start them on oxygen rather than waiting for the sats to go down. So you manage the airways accordingly. If there are concerns, you have to intubate, you have to give them 100% oxygen. At the same time, you would establish a venous access. So two large bore IV lines are mandatory. You access them, and obviously you will take some bloods, and when you have cannulated them, and what you would need to do is you take some bloods for full blood count, your routine chemistry, which is your urea electrolytes, LFTs. You will take blood from cross match, because the child might need blood in case of major burns. You check the carboxyhemoglobin levels, and in case of like burns to the chest, circumferential burns to the chest or head and neck, you do a chest x-ray as well. And for electrical burns, ECG is important, because that can lead to arrhythmia. So this is very, very important. Now, when you have taken your the bloods, it's important you give them proper painkillers, because you've got an IV line. So you can give them IV morphine, you can give them IV paracetamol. So pain control, either oral or IV, is mandatory, because if they are in pain and they've got anxiety, it's important that you address it. In the meanwhile, you should also manage for emergent injury. So sometimes the injuries are emerging because the damage process is ongoing. So as the injuries are evolving, you have to manage them accordingly. If the total burnt surface area is greater than 10%, then we have to start them on fluid resuscitation. And I will come in a moment to how do we give them resuscitation fluids, like we use a Parkland formula. I will come to that later on. In the meanwhile, it's also very important that those who have got major burns, more than 10% skin surface burn, you need to monitor their input and output. So obviously, when you're giving them fluids, you will be monitoring input. At the same time, you will put a Foley's catheter, and you will monitor the output as well. In kids, they require at least, the output should be at least 1 mils per kg body weight per hour. So this is very important, that they should be maintaining 1 mils per kg per hour output. And because they would not be able to eat, so NG tube is also important, that you pass an NG tube, you do the gastric decompression, and then later on you can feed them through that as well. So this is the general treatment of major burns. So in emergency department, when somebody comes with a burn, so you always start with the airways. You look for the airways. If they are concerned, you will involve the anesthetist. If not, move on to the breathing. Remember, start them with 100% oxygen, and attach them to the monitor. Again, look at the carbon monoxide level, subtract it from the room saturations to give you the actual saturations. Pass an IV line, take some bloods, which would help you. Give them some painkillers. Do a assessment of the burnt areas, how much percentage of the skin has been burnt, and if needed, then start them on resuscitation fluids. And at the same time, you can do adjunct investigations as well if it is needed, like a chest x-ray in case of burns to the chest or head and neck. And in electric burns, you will do an ECG. So these are mandatory. And then later on, you can pass in Foley's catheter, you can pass an NG tube. So this is the emergency management, which you should be very good at. You should be very familiar with these processes going on. This is like, could be the life saving for that child. How do we calculate the percentage of the burns? Now, different formulas are used, different types of charts are used. One is the London Brower maps, which we use. they're a bit confusing because they are used for different ages, for 2 years, greater than 2 years, and they are used in different centers. So we have got printed maps, and then we can use these maps, and we can like put, like for example, if the burn is on the right hand, so you will just use this map. You will draw over here, and then you can know by the chart how much area has been burned. More, but some doctors find it very confusing. So then we have got an alternative. We have got the Palmer method over here. The Palmer method uses the palm of the child, not your palm. It should be the child's palm who has been burnt. So the palm is equal to 1%. So just using the child's palm and you putting on the burnt area and see how much of that it. So you can get an idea how much percentage of the skin area is burnt. So if it is equal to a palm, it is 1%. If it is less than that, you will say, oh, well, it is less than 1%. If it is more than that, obviously you'll see how many palms, are equivalent of the burn area. And again, when we are assessing the burnt area, it is always the blistered and the charred area. So you will look at the blistering, you will look at the charred or the leathery white area. We never use just the red skin in in calculating the area of the skin that has been burnt. So blistering is a charred is involved, but pure erythema is not used in assessment of the total skin area that is burned. So that way we can determine the percentage of the skin that has been burnt by that particular burn. Now, as far as giving fluids in burns is concerned, so if a child has got severe burns, it will more than the 10% of the body surface area has been burned, then we use a Parkland formula to give them a resuscitation fluid. So Parkland formula is that the body surface area burnt, let's say 10%, 12%, you multiply it by the weight of the child and you then multiply it by the 4. So that would give you, like for example, if a child who's got 10% burns and he weighs 15 kg, so that would be 10 into 15 into 4. That would be 150 into 4 would be 600 mils. So this 600 mils is the resuscitation fluid. Now this half of this resuscitation fluid, let's say the half of this would be 300. So 300 mils has to be given over the first 8 hours of the burn. Now this is, again, this is very important. This is 8 hours starting from when the burnt occurred, not from when the child was brought into the hospital, because the child might have been brought to the hospital late while the burnt occurred like maybe 2-3 hours ago. So it's important that you calculate this time from the time of the injury, from the time of the burn. So this 300 has to be given within the 8 hours of the injury, and the rest 50% would be given over the next 16 hours. So this is the resuscitation fluid. Now this does not include the maintenance fluid. To this you would add maintenance fluids. Maintenance fluids, normally for burns we use Ringer's lactate as resuscitation fluid, or if nothing is available then you have to use normal saline. Maintenance fluids are 0.9% saline with 5% dextrose. These are the maintenance fluids. And maintenance fluids, you know that it is given like 1000 mils for first 10 kg, or in other words 100 mils per kg for the first 10 kg. Then it is 500 mils for the next 10 kg, or simply it would be 50 mils per kg for the next 10, 20 mils per kg for every kilogram above 20. That is how you would calculate. So if a child who is, let's say, 15 kg, so he would be having 1000 mils plus 50 per kg. So 15 to 5 would be 250. So he would be needing 1250 mils over 24-hour time period. This is how you would calculate the maintenance fluid. So we have to give them the resuscitation fluid as well as the maintenance fluid if the total skin area burnt is greater than 10%. If there are signs of infection as well, then we have to give them pseudomonal cover, or if they are suffering from staphylococcal sort of infection, then we have to give staphylococcal cover as well. Like for example, we can give them vancomycin and we can give them flucloxacillin. If they need pseudomonal cover, then you probably have to give like tazobactam or piperacillin plus sulbactam combination, or whatever your local trust or your local hospital policy is. So you will give them antibiotics according to that. But if not, again, many textbooks of pediatrics, they mention about the good drugs which have got good anti-pseudomonal cover. You should be using that. So this is how we give fluids in burns. Now, moving on to the uh, criteria for transferring a child to a specialist burn center. Now, remember, not every child needs to be sent to the burn center. In the UK, here, any child who has got more than 5% of the burns, they need to be transferred to the regional burn center. Or any burn, irrespective of the body, any burn that involves the face, that involves the hand, that involves the feet, that involves the perineum, or is over a joint surface, that needs to be referred or transferred to the local burn unit. Normally, I mean, it's not simply that you just make them sit in an ambulance, you send them, you usually send them the images first to their local burn center via a secure image teleportation channel. And then they look at the images, they give you advice, and if they want to see them immediately, they will tell you that you send the child to them. Any circumferential burns, because circumferential burns are notorious for causing necrotizing fasciitis. So it's important that circumferential burns are discussed with the original burn center and they are sent to them. Any burn which is associated with another injury or with inhalational injury, that again needs to be discussed or sent to them. Suspected NAIs, non-accidental injuries, where a child has been deliberately burnt because of different reasons, they have to be discussed. And obviously, in that case, you have to involve the social services. You might have to involve the police as well. All electrical burns and chemical burns, they also have to be sent to the specialist burn centers because that might require a bit of specialized care. So these are some of the criteria which we use to assess those burns which are caused by these things, and they need to be sent to the regional burn center. So usually we send them the images, we talk to them, and then depending on their expert advice, either they would need to see the patient there and then, or they might see the patient the very next day. So usually we give them a copy of the notes and then they are seen by them. So this is in a nutshell how burns are managed in pediatric practice. So again, just to summarize, most of the burns are caused by scalds or touching the hot objects. Again, most of the burns, they are usually superficial, like superficial partial thickness burns. Most of these burns would blister. It's important that you de-roof the blister after giving them proper analgesia. If they fulfill the criteria for being referred to specialist center, you will send the images to them, you will discuss it with them if they want to see them, well and good. If not, what you will do, you would apply paraffin impregnated dressings, gelinet dressings, and you will review the wound every 48 hours, because sometimes there might not be blisters, like, you know, they're not evident the first 24 hours of the injury. The blisters might appear later on. So it's important that you review the wound every 48 hours. So if there are later blisters have like appeared, you would de-roof them, you would clean them, and you will further do the dressings. And as I told you, that usually takes around 1 to 2 weeks for these minor burns to heal. Major burns could even take longer one, and those, like, you know, deep partial thickness burns and the full thickness burns, they might need some form of skin grafting. So they need to be transferred to the specialist tertiary care centers where the burns are managed, and later on they can have like plastic surgery or cosmetic surgery you know, to improve the cosmetics of that burned area. So this was all about pediatric burns. I've tried to, it's a very like complicated and big field, but I've just tried to summarize it in a few minutes for you to understand it. But still, if something is missing and if it is not clear, you can put your questions in the comment section below, and I would answer them. So this was all about pediatric burns. So if you haven't subscribed to my channel yet, well, what are you waiting for? Subscribe. And if you have liked this channel, if you like this video, sorry, just press the bell notification, press the like button, and also press the bell notification icon. So whenever I upload a new video, you are always on board with me. So, guys, thank you very much. Have a good day. Bye bye.